Canadian drug importation is an idea that's been around for 20 years, and the Partnership for Safe Medicines has been documenting the development of this policy since its birth. In this video, we'll explain how the idea is supposed to work, where states are in their attempts to make it work, and some of the problems they're encountering. If you're a state legislator or advocate considering Canadian drug importation in 2021, this video is for you. First, an explanation. Today, medicine comes to U.S. patients through this route. Pharmaceutical manufacturers make products within the U.S. or elsewhere and directly import themselves into the country. They sell them to wholesalers, and eventually pharmacists and other licensed professionals will dispense them to patients. Each of these entities has a strong U.S. presence, including personnel and property. Because U.S. federal or state regulators license every single entity in the supply chain, we call it a closed, secure drug supply chain. If one of these entities lies to you, you can hold them accountable, and if necessary, you can bring them to court without having to cross national boundaries. Canadian drug importation advocates want to do it this way instead. They want to have a foreign wholesaler, who may have no legal presence in the U.S., buy drugs from a manufacturer and send them to a U.S. importer who arranges for the drugs to be tested, repackaged, and relabeled, and then sold into the state. Because some of the entities in the supply chain are regulated by a foreign regulator rather than a domestic one, we call it an open supply chain. It sounds simple and seems to have only a little more risk, but states are discovering that importation is harder than it looks. Maine hasn't submitted their application to HHS yet, but a Freedom of Information Act request that we filed allowed us to see this valuable document. It showed us that once you figure in rebates, Medicaid programs like Maine's get medicine cheaper than Canadian provinces do. Since none of the medicine bought from Canada qualifies for rebates, fuzzy math about how drugs are cheaper in Canada starts to fall apart. The 50 drugs Maine studied would have cost nearly $1 million more if Maine had bought them from Canada, and they're not going to do that. Colorado spent $1 million this year developing their importation plan. They've just announced they won't have anything to submit to HHS until early in 2022. In the meantime, they're spending a second $1 million on staff developing it. Colorado still doesn't know whether any Canadian wholesaler will work with them. And they've removed both Medicaid and 340B from their plan because it already gets medicine cheaper than Canadians do, reducing the savings that Colorado had hoped to make. After a year of work by staff in half a dozen state agencies, New Mexico released their draft plan and will probably submit their final to HHS any day now. They don't have any Canadian vendors willing to participate, and like Colorado, they removed Medicaid from the plan because they already get medicine cheaper than the Canadians do. There are a number of problems with their application, including the lack of liability protection for healthcare professionals who might inadvertently dispense counterfeits, and a failure to restrict pharmacy benefit managers, hospitals, and insurance companies from marking up the cost of Canadian medication until it's the same price as U.S. medication. Florida submitted its plan in late November, and there are many issues with their proposal, but there are two we'd like to point out. One, there's no Canadian vendor willing to participate, and two, they said they should not be required to test the medication they buy. We're honestly gobsmacked by this. Florida was ground zero for an enormous counterfeit medicine scandal that led to the calls for the creation of track and trace. How can they want to skip the testing step? Additionally, Florida circulated an RFP seeking a vendor to run their importation program. It paid $30 million over 3 years, but that wasn't enough money. The contract was just to run the logistics, compliance, and customer support for the program. It didn't include the cost of buying medication, testing, or repackaging. How will your state justify spending money to hire a vendor to run a program like that in the middle of a pandemic? At a macro level, Canada has enacted new regulations in November that ban wholesalers from exporting any medication that might cause or exacerbate a shortage. Canada's drug supply is very small compared to the US, and they don't make the majority of their own medicine. They are perpetually juggling shortages. Since federal law only permits importation from Canada, and Canada has effectively closed the door on exporting their drugs, it doesn't seem possible to implement this policy, and any money your state spends on implementing it is just money down the drain. If you're a legislator or advocate looking to address healthcare costs, and specifically the cost of medicine, this idea will burn tax dollars and you'll have nothing to show for it. I suggest you look at a couple of issues. One, regulating pharmacy benefit managers. With the decision this last week in Rutledge versus PCMA, states can now regulate how pharmacy benefit managers spread priced pharmaceuticals to take profit from consumers and undercompensate community pharmacies. Also, don't underestimate the power of generics. Colorado published the list and quantity of medicines they wanted to import. We analyzed it and found that they were importing brand name medicines when cheaper generics already exist on the market in Colorado. They could save $43 million in a single year just by switching to generics. That's where Colorado should be focusing its attention. In fact, some generics are actually cheaper in the US than in Canada because of the size of our market. If you want to learn more about these programs and the problems states are having implementing them, follow us on our website at www.safemedicines.org.